One of the all-time great writer and philosopher, Leo Tolstoy, had said, men can withstand epidemics, men can withstand horrors of the physical illnesses or diseases, men can tolerate agonies of the soul, but for all time, the most tormenting tragedy for the man has been, is, and will be the tragedy in the bedroom. I would like to thank organizing committee for giving me this opportunity to present in front of you. We all know that sexual expression is important for part of our life. Problems with sexual functioning will cause psychological problems and other problems in their life. One of the all-time great writer and philosopher, Leo Tolstoy, had said, men can withstand epidemics, men can withstand horrors of the physical illnesses or diseases, men can tolerate agonies of the soul, but for all time, the most tormenting tragedy for the man has been, is, and will be the tragedy in the bedroom. And not to wonder, we doctors who are supposed to take care of the patient and provide relief, we are responsible for 20% of the sexual dysfunction in this male because of the medication. It has been found that almost 1 in 5 patients, those come to the sexologist or in any OPD, the 1 in 5 patient will have sexual dysfunction will be taking some kind of medications. So I am here to tell you about certain medications that will be responsible for causing this sexual dysfunction. I will skip psychotropic medications because that will be a separate workshop tomorrow. It is difficult to conduct in 20 minutes. I will be skipping recreational drugs here also, like other opiums and like that. I will be telling you about main drugs other than the psychotropic drugs. So most important category is antihypertensive medications. So it has been told that it has been found in studies that older generation antihypertensive drugs like thiazide diuretics, spironolactone, then these beta blockers, then centrally acting adrenergic agonists are responsible for, antagonists are responsible for this sexual dysfunction. There are various studies. I will wait for the laptop to begin so that I can tell you about those studies. But it has been said that diuretics, that is thiazide diuretic, is one of the most implicated class of drugs that can cause the sexual dysfunction. The mechanism of action of diuretics is not known. The way by which it can cause sexual dysfunction is not known. But it is postulated that it can be because of the low volume or decreased volume of the blood and decreased blood supply to the penis. So thiazide diuretics are one of the responsible group of drugs that can cause sexual dysfunction. It can cause erectile dysfunction. It can cause even decreased libido later. Thiazide diuretics are responsible. Then spironolactone. We know that spironolactone is aldosterone antagonist. This also has dihydrotestosterone antagonist property. It can act at these levels and it can cause sexual dysfunctions like erectile dysfunction, decreased libido and gynecomastia also. After that, one of the most important drug is beta blocker. Almost 20% of the patients taking beta blockers are responsible for the erectile dysfunction. The mechanism of action could be anything like it can block central sympathetic activity, then it can, because of the sedation and depression, it can cause decrease in the libido, it can decrease it can cause vasodilatation in this. So regarding these diuretics, in one of the MRC trial, it has been said that incidence of patient withdrawal from the study due to impotence was more than double with diuretics compared to beta blockers and several fold higher than the placebo. In this MRC study, there are three groups: the patients taking diuretics, patient taking beta blockers, and there was a placebo group. So it was almost highest for the thiazide diuretics, and then beta blockers was in between, and the placebo was almost 33, only 3% patient reported with this, there was withdrawal of medications. With this thiazide diuretic, not only as a monotherapy, but when it is given as an adjunct therapy, then also it can cause sexual dysfunction. And Williams and colleagues have quoted that diuretic added to the other therapy or used with other medication can cause impairment in the sexual function, and mainly it was the erectile dysfunction. In one study, that is trial of antihypertensive interventions and management study, patient randomized to chlorthalidone, almost 28% of them developed erectile dysfunction, while it was with atenolol, patient randomized to atenolol, only 11% developed erectile dysfunction, and in placebo it was only 3%. Another study, that is treatment of mild hypertension study, that is Thomas, patient randomized to chlorthalidone have been shown to develop erectile dysfunction even after 2 years of taking these medications. As I said, the mechanism of increased erection problems with thiazide diuretics remains unclear because diuretics have no known important central nervous system or autonomic nervous system effects. Regarding spironolactone, I have already told you. So I have told about the MRC trial. In one of the study, Coe and associates have told, after reviewing the literature, they have told that there is increased risk of sexual dysfunction and impotence. Regarding mechanism of action for these side effects, there is reduction in central sympathetic outflow, there is impairment of vasodilatation of the corpora cavernosa, and there is effect on luteinizing hormone and testosterone secretion. These are decreased, and there is tendency to produce sedation and depression, which can cause loss of libido. There was something called nocebo effect. It has been proved in the Italian study of 96 hypertensive patients taking antihypertensives. These were divided, the patients were divided in the three groups. The first group was, they were not told about the medication they are taking. They were just given the medication. The second group was given the medication and they were told that they are taking propranolol or beta blocker. And in the third group, they gave the medication and they counseled to them and they gave information to them that these beta blockers can cause sexual dysfunction. So after that, it was found that erectile dysfunction was 10-fold higher in the third group. That is the patients who were given beta blockers and were informed and counseled. So it was 31.2% compared to with the first, that is 3.1%, and the second group were just told that they were given beta blockers, they were in between them. So this nocebo effect is a psychological effect, not a pharmacological effect. So this concept has been told in Italian study. Now newer beta blockers have been used, like nebivolol may exert beneficial effects on erectile dysfunction. Substitution of these older beta blockers with nebivolol have been shown to improve the erectile function in males. Also cardioselective beta blocker acebutolol has beneficial effect in these patients. So the simple thing is that older generation beta blockers has to be stopped, or has to be, we have to stop that and then we can shift them, like with the help of the primary care physician or general physician, we will have to shift them to the cardioselective beta blockers. Then centrally acting anti-adrenergic agents like methyl dopa and clonidine, they can cause decreased libido and ejaculation by decreasing sympathetic outflow. This can cause erectile dysfunction, decreased libido, and problems with ejaculation. Nowadays, like methyl dopa is not used because of the side effects which are severe, so that is rarely used. Then vasodilators, like direct vasodilators like hydralazine and minoxidil may produce erectile dysfunction and priapism, but this appears to be uncommon. Angiotensin receptor blockers, we know that angiotensin 2 plays a significant role in pathogenesis of erectile dysfunction. When intracavernous injection of angiotensin 2 is given, it leads to the termination of the spontaneous erection, while the intracavernous injection of the losartan had the opposite effect. So, in one of the study of 82 hypertensive male patients with erectile dysfunction while on various antihypertensive drugs, losartan resulted in a marked increase of self-reported sexual satisfaction. While in another study with patients, 110 patients, valsartan and atenolol were studied, and valsartan was found to increase sexual activity. In one study by Siza et al., they studied almost 2,202 patients. They reported increase of sexual intercourse per week with valsartan. In another randomized control study, studied up to 3,302 patients, valsartan was found to improve all aspects of sexual function and particularly erectile function. These are the few another studies. Because of lack of time, I will not go into that. I want to mention here that angiotensin receptor blockers, angiotensin 2 receptor blockers are the not only they cause sexual dysfunction, but they improve sexual function in the erectile dysfunction or sexual dysfunction caused by hypertension patients. In these patients, it will improve erectile dysfunction or sexual functioning. The angiotensin converting enzyme inhibitors, they reduce angiotensin 2 production. They reduce conversion of angiotensin 1 to angiotensin 2. And another mechanism is that it also attenuates the degradation of bradykinin. Bradykinin is one of the hormone or the chemical which is known to activate nitric oxide release, and thus because it attenuates the degradation of bradykinin, there will be excessive nitric oxide release, and this will help corpora cavernosum relaxation and will help in the erectile function. Krug and associate reported that patients taking captopril had less sexual dysfunction than those taking propranolol and methyl dopa. In another study by Suzuki and colleagues, they studied 156 hypertensive patients. They reported that captopril may have advantages over a thiazide diuretic, atenolol and nifedipine in terms of quality of sexual life. But here we have to remember that ACE inhibitors are inferior to angiotensin 2 receptor blockers with respect to the erectile function, possibly due to incomplete blockade of the angiotensin 2 production. Then calcium antagonist, calcium channel blockers, the studies are very inconclusive. There is no significant data available because these calcium channel blockers do not exert a beneficial effect of angiotensin receptor blockers on the penile structure. Kroner and colleagues studied 134 patients in which nifedipine diltiazem had showed a trend toward improved sexual function, verapamil had no effect. So, but in some patients, gynecomastia and problems with ejaculation had been found. I will rush to the sides. The alpha blockers, daxogesin experience lowest incidence of erection problems. This is the chart where it was summarized. Just remember, older antihypertensive can cause higher rates of sexual dysfunction are there. The middle are they have a neutral effect, and the newer antihypertensive have positive effect regarding that. So just to summarize treatment, if there is a patient is taking antihypertensive medication, if there is no ED, continue current treatment. If there is ED, suggest lifestyle modification, and we can decrease the dose also. If patient is able to manage with it, continue. If not, we can add PDE5 inhibitors or substitute current treatment with angiotensin receptor blockers. If there is no ED, continue ARB. If there is ED, add PDE5 inhibitors. If ED goes, then well and good. If no, other treatment options can be explored. PDE5 inhibitors in patients with hypertension. PDE5 inhibitors may be safely co-administered, but American Urological Association in 2005 guidelines, they have told that vardenafil is contraindicated, but even newer study have told that all the PDE5 inhibitors can be used, but there are no contraindication, but they has to be used with proper care has to be taken, and cautions has to be taken. We have to also remember that some beta blockers also possess alpha blocker activity like labetalol and carvedilol. So we have to keep this patient taking these medications while giving PDE5 inhibitors. Finasteride and sexual dysfunction. We know that 5-alpha reductase enzyme inhibitors specifically having action at type 2. It is used for male androgenic alopecia and benign hypertrophy, benign prostate hypertrophy. We know that it helps in it blocks the conversion of hydrotestosterone to dihydrotestosterone, and it not only it also blocks the conversion of progestogens to glucocorticoids. Sexual adverse effects occur at the rates of 2.1% to 3.8% in these patients. Review of total 73 papers have shown that problems of ejaculation was there in 2.1 to 7.7%, then erection problems and libido problems. Dutasteride in these patients, patient taking dutasteride, it was seen in first 3 months of treatment, but after few days the problem was resolved. Actually, it is said that there is persistent finasteride syndrome, where it was said that when patient was given for almost 28 weeks, then these symptoms will not go, and it will cause physical symptoms, it will cause neuropsychiatric symptoms and sexual symptoms. So it has to be given with care in patients having a history of infertility. I will not go through these slides. I will mention few anti-cancer drugs and sexual dysfunction. Moles et al. Told that oxaliplatin causes in 42% of adult male patients erectile sexual problem was seen. Out of 38 cytotoxic anti-cancer agents, melphalan, vincristine, docetaxel, methotrexate and doxorubicin have said to cause these sexual dysfunctions. I will skip these slides where details were mentioned. Gabapentin and topiramate can cause sexual dysfunction. Orgasmic dysfunction is seen in both male and female, while decreased libido was seen in women. Dose reduction, timing of dose away from the planned coitus, substitution with different medication and co-administration of other medication is advised. Oral contraceptives can cause decreased circulating free testosterone and decreased desire in women, while depot medroxyprogesterone acetate can cause weight gain, depression, and vaginal atrophy and dyspareunia. So causes decreased libido in almost 15% of women. Another form of contraceptive can be considered in these patients, and estrogen creams can be used for those having the local problems. Then alpha blockers, tamsulosin was one thing which causes problems in 10% of the patients. Steroids and cyproterone acetate, cimetidine, digoxin. These three, cyproterone acetate, cimetidine and digoxin, has androgen receptor blocking property, and this can cause lack of sexual desire in both sexes and affects arousal and orgasm. Immunosuppressive drugs and protease inhibitor can also cause this. So just to tell you, just finish, last slide. So this dose reduction can be done, drug switching can be done, drug holidays rarely used, phosphodiesterase type 5 inhibitors can be used along with that, and estrogen cream to elevate local symptoms such as atopic vaginitis and dyspareunia can be used. understanding both the impact of a disorder and the effects of its treatment on both patient and their partners are critical to providing good clinical care. And it's important for the clinician to acknowledge and encourage discussion with patients. And most important is always have a liaison with treating physician or a doctor. As a psychiatrist, I can't, as I said, I can't stop the beta blockers and shift them to the cardioselective beta blocker. That has to, because in some patients that could be life-saving drug, like the patients with cardiac failure. In that case, in that patients, that could be life-saving, and if we shift those drugs, then that can lead to the patient. As it is said that sir salamat to pagdi 50, वैसे ही अगर patient salamat to sex 50, like. So we should not play with the life of the patient, and that's all from my side. Thank you very much for the patient listening.
Questions from the audience?
While prescribing PD5 individuals for patients under cardioselective drugs, you told some precautions to be taken. What all precautions are
Not for cardioselective, for these alpha blockers.
alpha blockers? Like what all precautions?
No, we have to just tell the patients that this can cause can cause hypotension, and we will have to look for that. Yeah, that's it.
And do all beta blockers cause ED, or there are some like propranolol and all which do we cause?
It was highest with the propranolol. Then atenolol is in between, and with newer beta blockers it was less. Nocebo. Yes.
So many times we have to conceal all these patients having such side effect, all these drugs. So whether it is better not to tell, or in this era everything will be revealed. So many times, even now the law says everything should be revealed to the patient. But even enforcement is much more. So
Yes,
what
sir.
to do?
It's like it's a dilemma for any treating physician, because in even psychiatry patients also we have to tell them with antipsychotics, with antihypertension, antidepressants, all can have these sexual side effects. So it is better to tell, because they will report better. Or else another option is that in each follow-up you can ask about how is sexual functioning, like taking personal history. We can ask is everything is good, sexual life is good, and then as we ask for bladder bowel, and that we can ask another question, is everything fine with the sexual activity. So that can be another alternative for that.
Thank you, sir. Now
Thank you, sir. I request Dr. Nandakishore sir to felicitate Dr. Atul Dhage, sir.